Okay, so right now we're going to talk about audiological treatment. So report writing, referrals, and some counseling. With report writing, there's going to be pediatric report writing if you're working with infants or children. With pediatric report writing, you have to take a very detailed case history. So in addition to their name and their address, their date of birth, the reason that they're there, you also need to know if the mother was on any medications during pregnancy, if there were any complications during pregnancy, during delivery or after pregnancy, the drugs used, alcohol, birth weight, C-section, whether there was anoxia, complications, whether or not the infant was in the incubator. Remember, you need to get this thorough case history because some of the case history might indicate a warning or a high risk registry for the hearing loss. So there are also questions to ask in the waiting room. Is there speech delay? Remember, the number one reason that children visit the audiologist is to rule out hearing loss as the cause of the speech and language delay. So you're going to ask, has there been a speech delay? What's the motor development like? In the waiting room, watch the child, see the child's gait, see how the child interacts with the other people in the waiting room, with the toys. Are there seizures? Was there illness? Was there a high fever, meningitis? Any accidents? History of hearing loss, history of ear infections. So middle ear infections, fluid in the ear, all of this stuff is going to affect your case history and your ability to get a good exam from the child and to figure out what's going on. Also, were there surgeries? Is the child on medication? How is the child at home? Are the parents around? Is the child learning one language or two languages at a time? That might contribute to a speech and language delay. Are there other siblings? Is there an older brother that does all the talking for the child? How does the child gesture to communicate? Does the child point and the mother just grabs the toy that he wants, or does the child have to vocalize to get what he wants? Does the child use whole words? Is it that the child is on target or not? For adults, you also need to ask their name and get their information, medical history, was there disease, why are they seeing you, do they have a complaint, do their ears hurt, was there a previous hearing evaluation, how long ago was it done, do you have a copy of it? I always like getting previous hearing evaluations because they should kind of match up to your current hearing evaluation. They should be somewhat similar, maybe a few dB different depending on how long it's been, but it's good to get previous hearing evaluations if they've been there. Is there a hearing loss? Does the person think they have a hearing loss? Did something happen during their childhood? Did they have a lot of ear infections when they were a child? Do they have any surgeries? Do they have tinnitus? Do they have ringing in their ears? In which ear? How intense? What do they do for a living? What are their hobbies? Right? So remember, men are more likely to have hearing loss than women. A lot of it has to do with their professions and their hobbies. Vertigo, does the person have dizziness? Any illness? What medications are they on? Are they taking any ototoxic drugs? Does the patient use hearing aids? When you're writing your report, the first paragraph you identify your patient. The second paragraph you write about the degree of hearing loss, the severity, the type of hearing loss, the tympanograms, whether they're acoustic reflexes or not. And in the third paragraph, you also add your speech information in that second paragraph, your speech recognition scores, their threshold. In the third paragraph, you can make recommendations for hearing aids, speech and language therapy to avoid noise exposure, and to follow up. I've seen very, very long reports. I've also seen very short reports. It depends on the place that you're working at, how detailed they want you to give their reports. Some offices and hospitals send home the audiograms, others don't, and I know at our clinic they just describe the audiograms. They don't let the patients have them. I think you should send them home though. So if the patient signs a release form, then you can send the audiogram and the information off to other third parties that might be interested in knowing, for example, the speech language pathologist. When you're writing your audiogram and when you're writing any report, avoid verbosity. I hate verbosity, right? So it's one of the reasons I love audiology. It's very straightforward, cut and dry, write what you found, and that's that. Make sure that your reports are well written and make sure that you proofread because it's not just the patient. Well, first of all, it would look very unprofessional to have a report with spelling and grammatical errors for your patient, they'd think, who is this doctor testing me? And then to send it out to another professional, you're not going to get back any referrals if your reports are not well written and proofread. Audiologists work closely with otolaryngologists. So if you remember, audiologists are the non-medical treatment of hearing loss. So the audiologists are the experts in diagnosing hearing loss, whether it's the outer ear, the middle ear, the inner ear, the auditory nerve. They are experts in hearing aids and cochlear implants and assisted listening devices and oral rehabilitation, but they are not medical. So the audiologist will not be inserting the cochlear implant. The audiologist will be programming the cochlear implant. They work very closely with otolaryngologists. So the otolaryngologist or an otologist, an ear doctor, will be inserting the cochlear implant. So if you think oto means ear, laryngologist, that's an ear, nose, and throat doctor. An otologist specializes in just the ear. So now these people, they know everything about, well, otolaryngologists have to know a lot about the ear, nose, and throat. So they might not know as much about hearing as the audiologists, who are the experts in hearing. Audiologists might also work with clinical psychologists, especially if there are children involved. If the patient's problem is complicated by an emotional disorder, you should state your claim and put in the referral. Genetic counseling. You are required by law to inform a family about medical genetic counseling. So, for example, if a family has a child with hearing loss, remember, most of the time it's caused by a genetic disorder. Most of those genetic disorders are recessive. The family has the right to know the chances that their next child will also have a hearing loss. The families might be interested in the etiology or the prognosis of the hearing loss. And like I said, the probability that a later child will have a hearing loss. So an audiologist should ensure that a family knows that genetic counseling is available and where to refer. So genetic counseling, they would look up at the DNA of the child and the parents, and they would be able to determine who's a carrier of what and what the chances are of another child with hearing loss. Of course, audiologists work very closely with speech-language pathologists. Remember, if you can't hear, you will not learn speech and language. But audiologists might have a limited clinical background in speech and language. So we refer. So an audiologist usually sees patients because the SLP wishes to know if the communication disorder is related to the hearing loss. Audiologists and speech pathologists should collaborate. You want the best for your patient. So if the child has hearing loss, the audiologist is the expert at diagnosing the problem, treating the problem with hearing aids or assisted listening devices or cochlear implants, and the speech-language pathologists are the experts in having that child develop speech and language. So the report should be frank and direct. They should state the type, the extent of the hearing loss, the effects that the hearing loss is having on the patient's speech. For example, the child is missing between 1,000 and 4,000 hertz, and the child is missing the F sound, the TH sound, the S sound, the high frequency sounds. But the audiologist will not make specific recommendations regarding therapy. That's the speech-language pathologist's role. However, the audiologist could recommend that the child come back for further up testing after a few months. Audiologists also work with teachers of children who have hearing loss. So this is another alternative. If you decide you don't want to be an audiologist, or you decide you don't want to be a speech-language pathologist, you could be a teacher of a child with hearing loss or teacher of the deaf. So with this title, you are a teacher first. You are there to teach social studies and math and English and writing and reading, but you have an understanding of hearing and hearing loss and hearing aids and classroom acoustics, and you help manage that child's education. So children with hearing loss, they used to go to schools that were, solely that were only with children that had hearing loss, and now children are much more likely to be mainstreamed. The teachers might therefore have no formal preparation in the impact of hearing loss. So these teachers with, 28, 30 students in their classroom, they have a lot to manage. They might have a child or two with hearing loss. They might not be trained in hearing loss. They might know nothing about hearing loss. So they are going to rely on information provided by the audiologist. Every school district will have an audiologist that works for it and works with it. And it's the role of that audiologist to help the teacher set up the classroom and manage the classroom and give that child with hearing loss the services that they need. Now, sometimes school districts might be very, very stretched and the audiologist might not be there or might not be available. And it falls on the shoulders of the speech-language pathologist to work with the teacher to help that child with the hearing loss. So that's why speech-language pathologists are required to have these classes in hearing and hearing loss, because this could fall onto your shoulders. So you have to teach that teacher about the impact of the background classroom noise, the fatigue that results from straining to hear, how high-frequency sounds might be missed, even with amplification, and how to manage a classroom of children with hearing loss. So give that child the FM system, make sure the child is on, make sure the child can see your face, have the child sit as close to you as possible, preferential seating, make quiet areas for work, do the best you can to keep that classroom environment quiet to reduce ambient noise and background noise so as to improve the signal-to-noise ratio. Audiological counseling is based on the well-patient model. Many of the patients are seen as psychologically normal individuals trying to cope with the disruption of hearing loss in their lives. So this is where oral rehab comes in. So if any of you are taking my course in oral rehab next semester, we're going to talk a lot about audiological counseling. The goal is to help patients achieve independence and to learn how to solve their problems that are associated with hearing loss. And very briefly, so we're going to spend a whole semester on this, we're going to talk about communication strategies training. So the first thing you can advise a person with hearing loss to do is to tell others that they have a hearing loss and to let them know the best way to communicate with them. This isn't always easy. Imagine something that you are most self-conscious about, and then that thing being what you need to introduce yourself as saying. Okay? So sometimes it's hard for people to say that they have a hearing loss because hearing loss they might consider themselves old, or only old people had hearing loss, when they were young. So it could be hard for someone to admit that they have a hearing loss. But the best thing they can do is admit that they have a hearing loss so that the people around them can better accommodate their needs. For example, if I was on the subway and I saw a man in a cast, with his leg in a cast, I would get up and I would give him my seat. However, if I did not see that cast, I would be less likely to get up and give the person my seat. So because hearing loss is an invisible condition, people might not realize that the person they're speaking with has a hearing loss unless that person says something. So the person with hearing loss has to let the people around them know that they have a hearing loss so that they don't think that they're ignoring them or that they're being rude or that they're dumb. They just need some extra compensatory methods. So they need the person who's speaking with them to look at them, to face them, to turn off the background noise, to give them a clear view. In larger groups, the person with hearing loss should position themselves towards the center of a group. At large gatherings, they should sit to the center of the room. They should speech read a person's lips, a person's facial expressions, a person's body movements. We can get a lot of information just by looking at someone. For example, maybe you have heard the expression, she has a spring in her step. What is a spring in a step? Is someone who has a spring in their step having a good day or a bad day? They're having a good day, right? If someone's having a bad day, they'd be more hunched over. They might not look at you. So we want to teach the person with hearing loss to read the whole message. It will help them better respond. Listening for context and key words, asking people to repeat or rephrase what they said that they didn't understand, and in noisy restaurants, asking to be seated in a quiet corner or an area with their back to the wall so that they don't have to worry about noise coming from behind. And I hope I see you guys in oral rehab. We could talk a lot more about those strategies.